I have no relevant financial disclosures, just Abbott Vascular, which doesn't relate to this talk. The objectives of this talk are to discuss the important coronary anomalies and to understand how this impacts a coronary angiogram and a percutaneous coronary intervention, to understand the role of additional imaging in coronary anomalies, and to discuss the role for revascularization in coronary anomalies. So I'm going to start out with a question. Which of the following statements are correct? Number one, the most coronary anomalies are associated with increased sudden cardiac death. Number two, there is a role for surgery or stenting in the treatment of anomalous coronary arteries. Number three, Al-Kappa is always identified in childhood. And number four, IVUS has no role in the diagnostic testing of coronary anomalies. So they're going to let you put in your answers there, and we can see on the pretest question. And so almost everyone got that right. So that's good. That's helpful after lunch, that you probably already know most of what you need to know through this talk. But we'll go ahead with some other important things for the boards here. Coronary anomalies are the second most common cause of sudden death in young athletes. It's not necessarily associated with other congenital heart disease. It occurs in 0.6 to 1.5% of coronary angiograms. And most coronary anomalies do not result in signs, symptoms, or complications and are usually discovered really as an incidental finding. And it's important to know some facts about coronary anomalies. Although the majority of associated sudden cardiac death occurs during or shortly after exercise, sudden cardiac death has been reported in the sedentary state in patients with coronary anomalies. The clinical signs such as chest pain, dyspnea may be helpful, but about half of individuals with sudden cardiac death, that is their first presenting symptom. ECGs are completely unreliable as a screening test. Stress tests are not uniformly positive because of dynamic outflow, because of dynamic obstructions. And so you really have to understand the interplay between the anatomic features and the physiologic impact of the coronary anomalies. About 80% of coronary anomalies are hemodynamically insignificant and really just an incidental finding. Myocardial perfusion is not altered, and there's no risk of increased atherosclerosis. The most common of these abnormalities is a separate ostia of the left circumflex and left anterior descending coronary artery, and you see that as about 30% of all coronary anomalies. The next most common is the left circumflex coming off the right coronary artery or off the right cusp. And then there's a smattering of other ones. So this is the separate ostia. And you can see completely separate ostia of the left circumflex and the left anterior descending coronary artery. We see that all the time in a normal right. You want to use a larger catheter for the left circumflex and a smaller one for the left anterior descending coronary artery for engaging. And again, the next most common is the left circumflex coming off the right cusp. You notice this is a long left main coronary artery. You're saying we're not filling a territory. That's the left circumflex territory. So the first thing you're thinking of is it separate ostia? Is it coming off somewhere else off of the left cusp? And then you start thinking about, is it coming off the right or off the right cusp? And so that is the right coronary artery for this patient. And then you can see the left circumflex comes off as a separate ostia off of the right cusp. And this is, again, another patient who has the circumflex coming off the right coronary artery. Again, that long left main coronary artery look to it. A territory that's not being filled here in the circ territory. And then you can see the circumflex coming off the right coronary artery. And those are just some better pictures to try and engage it. You can see we switched out to a multi-purpose catheter to try and better engage that and visualize it better. So for the circumflex coming off either the right coronary artery or as a separate ostia off the right cusp, you can use a JR, sometimes a larger JR, sometimes an AR, sometimes an AL, sometimes a multi-purpose. But as you could see from the previous one, really guide support is usually problematic, and oftentimes where you see stenosis is in this longer segment, and so that can be quite a challenge for a percutaneous coronary intervention. So what about the right coronary coming off of the left cusp? So this is kind of normal looking left coronary arteries. And you can see that it's really very close to where the left main is. It's not usually hemodynamically significant, although it can be. You can use a multi-purpose, again, an AL, a JL catheter to try and fit into the right coronary artery coming off of the left cusp. So this is a case that I saw about 10 years ago or so. It's a 47-year-old woman. She came in, she had ulcerative colitis by her history and had a day's worth of chest pain. Her ECG showed sinus tach and some nonspecific changes, but wasn't really all that remarkable, and had a troponin T that was elevated at 0.18. And so she came to the cath lab. You can see that her left main looks long, and you're not really seeing anything in that left circumflex territory. And, sorry, hang on, I'm missing my rights here. Up at the beginning. And there's the right coronary artery. You can see it's a large right coronary artery. And those were the lefts. And so I did a root shot looking to see if we could see another takeoff of a vessel, which I could not. And so then the question again was, are we missing something? So we did a right ventriculogram looking to see if there was a coronary artery coming off the pulmonary vessels, which there was not. We did a left ventriculogram to look to see if there were regional wall motion abnormalities, which there were not. And this patient, after kind of exploring all of those options of looking, are we missing something in this patient who comes in with chest pain, has a positive troponin, and we're missing our circumflex coronary artery? The answer is no, we were not. So we actually did an MRI, which proved that she had myopericarditis and again showed that she had a congenitally absent left circumflex coronary artery, which was our diagnosis from the cath lab. So what about hemodynamically significant coronary anomalies? So these are the ones we're always worried about missing. These are characterized by abnormalities of myocardial perfusion. And really there's four major types. There's coronary fistula, there's the origin of the left coronary artery from the pulmonary artery, there is congenital coronary artery stenoses or atresias, and there's the origin of the left coronary artery from the right sinus of Valsalva with the passage of the vessels between the aorta and the right ventricular infundibulum. So these serious anomalies are very rare, and they're a minority of the congenital coronary anomalies that you're going to see. The majority of them are, again, coming off the wrong cusp or of the coronary artery. And you can see that fistulas are actually more common than most of the other anomalies that you will see that are significant. And so one of the questions that always comes up is the anomalous left main coronary artery and where is it running? And so one is a septal course. That is the one that runs as an intramuscular course through the septum along the floor of the right ventricular outflow tract. It travels upward in the mid-septum, then branches into the LAD and circumflex coronary arteries. There is an anterior course. That's the one that crosses the anterior free wall in the right ventricle over the pulmonary artery, then dives into the mid-septum into the LAD and circumflex coronary arteries. You have the retroaortic course. That's the one that passes posteriorly around the aortic root and then supplies the anterior surface of the heart by dividing into the LAD and circumflex coronary arteries. And that's the one that's going to have that posterior dot sign right there. And then there's the intra-arterial course, which is the one that runs between the aorta and the pulmonary arteries to its normal position on the anterior surface of the heart, diving into the LAD and circumflex arteries of the normal length and course. And so that's, again, your anterior dot sign. So again, you can look at different things with that, the anterior and posterior dot signs, as we just talked about. You can look at the left anterior descending coronary artery and whether it's a short or a long course. You can also look at whether or not there's septals coming off of the left main coronary artery to help you know which of these four types of anomalies of the left main coronary artery you have. And so here is a image of a left main coronary artery that's coming off of the right cusp. You can actually see that there's septals coming off of this one. I'll show you some other pictures which will show you very well. Septals again coming off of it, which helps you to know that it's going to be the septal course, which is again a safer type of left main anomaly. So the questions are, is it hemodynamically significant? Does it run through the great vessels? And this one was that septal course with a short left anterior descending coronary artery and septals coming off the left main coronary artery. This is a different anomaly. Again, the left main is coming off of the right cusp. There's your right coronary. And then you can see your left main. And maybe I'm running. There we go. Fairly short LAD course. This one was then IVUSed as well, and so I have the IVUS there for you to look at the left main to see again if it was compressible and if it was causing hemodynamic significance as one of the options on it. And if I'm patient through it, you will start to see it compress further out as we go. It never truly looks completely slit-like, but you can definitely see that there's some compression to it. Okay. So that was the intra-arterial left main coronary artery, and that was confirmed by CT scan. And basically my answer is, as most people's are, if you're having any doubt from your angiogram, get a CTA. The value of the CTA is really important. It can help you know if there's a slit-like opening. It can help you tell if there's acute angles of the takeoff. It can help you know what type of course it's taking, if it's intramural, extramural, or intramyocardial. It can tell you the length of the intramural or intramyocardial segments. Additionally, then, there have been studies that are looking at stenting of anomalous coronary arteries. This is a study that's looking at stenting of anomalous right coronary arteries. Patients ages 12 to 73, they were there with dyspnea, syncope, and no patients with sudden cardiac death and chest pain. All patients had IVUS as part of it, and about 2/3 of the patients ended up getting stenting. And this is because they could see off of the IVUS that it appeared to be significant and a component to it. And then the stenting resulted in a resolution of the intramural stenosis in all of the patients. And they've had good follow-up without any sudden deaths, but some in-stent restenosis. So there's a lot of surgical options, and surgery can be a challenge to it. If you do just plain old bypass surgery, you have competitive flow, and some of the issues is if you are getting stenosis really only part of the time with a dynamic constriction of the coronary artery, you sometimes have issues with graft longevity. So one of the other options is reimplantation of the coronary arteries. This can result in osteostenoses, and sometimes it's a difficult angulation to it. The preferred approach, if it's an issue with it running into an intramural and intramyocardial course, is an unroofing procedure to try and alleviate the constriction of the vessel based on that. So, with an anomalous left coronary artery, you want to consider repairing it after shared decision making. The anomalous right coronary artery, it's usually more selective and based on age and other signs that it's actually physiologically significant. So younger patients are more likely to have benefit from repairing that. You want to consider in patients who are having symptoms or decreased in an ejection fraction if they're asymptomatic and young, and have some evidence that it's physiologically significant even in young patients who aren't having much for symptoms. You still should consider repairing that. So fistulas is the next topic of what can be a hemodynamically significant anomaly. So this is a very large fistula of the left circumflex to coronary sinus. And most coronary artery fistula are congenital, but they can be acquired post-myocardial infarction, post-biopsy, post-CABG, PCI, AVR, myectomy, permanent pacemaker, or ablation. And they can have quite a number of different courses depending on where the fistula is going to. They can present with a murmur, chest pain, shortness of breath, heart failure, endocarditis. Sudden cardiac death is quite rare with coronary fistula. Some of the time it's really just an incidental finding. If they are hemodynamically significant or causing symptoms, then the treatment is coil embolization or surgery. And again, the indications are really ischemic indications, arrhythmic indications, endocarditis, ventricular dysfunction, or ventricular enlargement. If it's small and asymptomatic, you should clinically follow these patients up every 3 to 5 years. The guidelines, which is again things that tend to be tested on for the boards, the class 1 indications for evaluation of coronary artery fistulas. If there's a continuous murmur present, its origin should be defined either by echo, MRI, CT, angiography, or cardiac catheterization. If it's large, regardless of the symptomatology, it should be closed either by surgery or percutaneous routes. And if it's a small or moderate fistula in the presence of documented ischemia, arrhythmias, or otherwise unexplained ventricular systolic or diastolic dysfunction or enlargement or endarteritis, it should be closed via a surgical or percutaneous route. Class 2A is just clinical follow-up with an echo and symptoms and ensuring that it's not getting symptomatic. And class 3 is with very small ones. They just should not undergo closure of the fistula. So what about anomalous left coronary artery from the pulmonary artery? And this is a significant coronary anomaly. It's also called Bland-Garland-White syndrome. Its incidence is 1 in 300,000. It's a typically isolated malformation. Rarely does it occur with other congenital heart disease. There are 2 different forms to this. The first is the infantile form, which occurs in about 85% of the cases. And these children present with poor growth, tachypnea, irritability, or angina with feeding. 90% are fatal by 1 year if it's not repaired. The adult form can occur really because of collateral formation, and so that otherwise they wouldn't survive to adulthood. It occurs in 15% of the cases. The symptoms really vary, and it varies a lot depending on those collaterals, and it can occur because of ischemia or a steal phenomena, and it also can be associated with sudden death. So in hunting for trying to find an Al-Kappa patient, I went to one of my congenital colleagues, and they said this was an older patient with Al-Kappa, and it's an 8-year-old. And it was someone who was referred because of a murmur and was otherwise healthy. They had normal growth and development, normal activities, was an avid soccer player, never had chest pains or syncope. And the survival into adulthood is, again, 10 to 15%. Average age at presentation in the older population is 41 years, and the oldest reported was 83. And about 20% present with no symptoms, and most of the other patients are presenting with either angina, ischemia, an abnormal EKG, left ventricular dysfunction, mitral regurgitation, ventricular tachycardia, complete heart block, or sudden death. And this is that patient, again, with pre and post CT scans. And so they underwent repair. And what you see when you treat patients with their anomalous coronary artery coming off of the pulmonary artery and have surgical correction for this, that actually that post-operatively they can get quite a significant improvement in their ejection fraction. So the key points on anomalous coronary arteries for the boards are that 20% of coronary anomalies have the potential to be serious, so 80% are not serious. You want to suspect an anomaly when you see that long left main coronary artery, when you see a territory that doesn't look like it's covered, and you want to look for that intra-arterial left main coronary artery as the one to worry about, and that's the one that has the anterior dot sign and the slit-like left main. And I did put some answers in. Again, most coronary anomalies are associated with increased sudden cardiac death. That's not true because 80% are benign. Al-Kappa is always identified in childhood, again, is not correct because 15% is identified in adults. And IVUS can help you with identifying a dynamically compressed vessel. Thank you very much for your attention, and good luck on the boards.